very important is that today we can identify that some authors characterize as a phenotype in cardiogenic shock. And these phenotypes has a relationship with the etiology of shock and, of course, severity. And some patients, of course, present risk for develop cardiogenic shock, even when they present to the emergency. And there is some studies, maybe in the since the 80 in the last cycle, that patients with congestion, edema, pulmonary edema, and venous congestion, these patients had a high risk to develop cardiogenic shock during the course of acute myocardial infarction. So it's very important to identify the shock stage and recognize the impairment in the hemodynamics and mainly in metabolic derangements. And as I told before, the production of lactate by anaerobic metabolism. And we must, I think so, to be attempt to the toxicity of vasopressor support. These patients do not tolerate high doses for a long time without a new myocardial injury in cardiogenic shock. When we see this stratifying in considering the three types of hemodynamic and metabolic variables. In the red line, we have patients with hypoperfusion. These patients probably correspond to the type 3 of Forrest classification, low cardiac output without high pressures in elevated pulmonary occlusion pressure. These patients, for instance, could be hypovolemic. In green, the patients who present in a cardiorenal profile, cardiorenal phenotype. And you can see these patients present a high pulmonary systolic pressure, diastolic, and pulmonary capillary edge pressure. And finally, patients in blue present, I think, that the more severe phenotype of cardiogenic shock. These patients present with a cardiometabolic, and as you can see, a high level of lactate, and this corresponds to a very important compromise of the aerobic metabolism. These patients have also alteration in enzymatic profile and an inflammatory profile. Around 15–20% of patients who present with cardiogenic shock, they have a component of vasodilatory. So it's very important in these situations that we have safe hemodynamic monitoring in these situations. And this study was composed two cohorts of studies in North America. And you can see the mortality is high in the cardiometabolic, as I told you, and around 50%, a little bit higher than 55–56%. So nowadays, we still have a high mortality in cardiogenic shock. We can see that in this phenotype, more than 50% of patients will die. So an hemodynamic monitoring, very early intervention is fundamental for the success in treating these patients. This is the classification for the sky, showing from the A to E, the classification, stratifying the cardiogenic shock. And it's very important the moment when we decide to provide any type of hemodynamic monitoring for the treated of these patients. One thing that we have and we must have in mind is that hemodynamic, any one tool doesn't have treatment properties. And this is a big problem with a PA catheter along the last two decades, when there was a great expectation that just put a pulmonary artery catheter, Swangans, will save our patients. And the moment to start very close hemodynamic monitoring, for sure, should not trespass the C is that the classic cardiogenic shock. As you can see, the patient has manifestation of hyperfusion that requires an intervention. At this moment, it's very important that we have, independent of which hemodynamic tool you will use, that our patients have pulmonary artery catheter inserted, transpulmonary monitoring, echo, Doppler, any one of these tools, our patients should be stratified and should be the treatment accompanied by a resource like this.